Welcome back. Welcome back from Thanksgiving week. Hope you all had a safe and family-friendly time as we can during the pandemic. It is my pleasure today to introduce our visiting professor, Dr. Samuel Goldhaber, who is the section head for the Vascular Medicine and director of the Thrombosis Research Group within the Cardiovascular Medicine Division of Brigham and Women's Hospital in Boston. He is a professor of medicine at Harvard Medical School. So he received his medical degree from Harvard Medical School and he completed his internal medicine residency along with Dr. Martin Goldman at Peter Ben Brigham Hospital, now Brigham and Women's Hospital, and was appointed as chief medical resident at the Veterans Administration Medical Center in West Roxbury, now the VA Boston Healthcare System. He then completed his cardiology fellowship at the Peter Ben Brigham Hospital, now Brigham and Women's, and Dr. Goldhaber is board certified in both cardiovascular disease and internal medicine. Dr. Goldhaber's clinical interests include general cardiology as well as novel oral anticoagulants, stroke prevention and atrial fibrillation, reduction of inflammation to prevent myocardial infarction, and the epidemiology, management, and prevention of pulmonary embolism and deep vein thrombosis. He directs several continuing medical education courses for Brigham and Women's Hospital and HMS, including a 5-day update in cardiology for the practitioner and a 2-day course on thrombosis and thromboembolism. Dr. Goldhaber is committed to community outreach, and he helped found the North American Thrombosis Forum, a nonprofit organization which educates healthcare practitioners and patients, and he serves as the NET-Thrombosis president. His extensive research and publications focus on PE, DVT, and stroke prevention and atrial fibrillation. He chairs the steering committee of the ATTRACT trial, which is studying the optimal method for managing massive DVT. He is principal investigator of clinical and observational trials of PE and DVT prevention and treatment as well as stroke prevention and atrial fibrillation. His research has received funding from the National Institutes of Health. Without further ado, Dr. Goldhaber, thank you for joining us today, and I'll let you share your slides and get started.
Well, thank you very much. It's an honor to be here, to be Zooming with you. I'm going to discuss this morning COVID-19 and thrombosis, puzzlement, persistence, and prospect. I'm going to talk about the Spanish flu, symptoms, cardiac injury, and autopsy findings from COVID-19, as well as the epidemiology of COVID-19. Controversies about masking, the thrombotic effects of COVID, including venous, arterial, and MACE. Interesting data that have emerged on right ventricular remodeling as a prognostic indicator in COVID-19, the post-COVID syndrome, and then I'll take some reimagination of what the new normal might look like. Well, let's go back to 1720. It seems that history repeats itself every 100 years. The plague in 1720, cholera in 1820, the Spanish flu in 1920, and now coronavirus in 2020. As for the Spanish flu, these are photos from 100 years ago. You see these two ladies walking next to the park, and they're masking. Right next to Brigham and Women's Hospital is the town of Brookline, where I live. It's really a stone's throw from the hospital. And what I learned is that in 1918, there were so many who became sick from the Spanish flu right here in Boston that a huge tent field hospital was started in Brookline. This is now used as a little league field, and it was called the Brookline Hospital. There was some poetry written during the Spanish flu. I'll read one short poem. And people stayed at home and read books and listened, and they rested and did exercises and made art and played and learned new ways of being and stopped and listened more deeply. Sounds familiar. Now we come to COVID-19. The symptoms are relatively nonspecific: fever, fatigue, dry cough. It's not necessarily easy to diagnose. And the mechanisms of cardiac injury are thought to be twofold. One is cytokine storm, and the other is direct invasion of the myocardium. And you get elevation of inflammatory biomarkers, particularly with cytokine storm, elevations of IL-6, D-dimer, ferritin, and LDH. During the first 2 weeks, there's this early stage of infection where the lymphocytes get invaded and there's a lymphocytopenia. Then by about 5 days, one starts to see COVID pneumonia with abnormal chest imaging. And then the host response kicks in, and this is where there can be severe illness with a host response of elevated inflammatory and cardiac biomarkers. Now, the risk factors for COVID are similar in many respects to the risk factors for MI, stroke, and pulmonary embolism: increasing age, obesity, immobility, cigarette smoking, pregnancy, and the male gender. And I already mentioned some of the major complications of inflammation and cytokine storm. Patients develop ARDS, and they can end up in the intensive care unit. Here you see another conception of the mechanisms of cardiac injury. You start off with the virus, and it can go the route of immunopathology with hyperinflammation and strike the heart, or ARDS with respiratory failure and hypoxemia, having deleterious effects on the heart, or direct myocardial injury. And what do we see as clinicians? We can see biomarkers of injury, arrhythmias, acute coronary syndrome, HFpEF, and HFrEF. Here are some autopsy findings. This patient was stricken with ARDS in the intensive care unit. You can see the lungs are soggy. They weigh about twice what they should. This patient had pulmonary edema. The right ventricle is dilated and distended. And if you look in the lungs where these green arrows are, you will see these infamous microthrombi, typical of COVID. Now, one of the first things to happen is the T cell destruction with this lymphocytopenia. And the lymphocytopenia is a marker of a poor prognosis. And these patients' survival is not nearly as good as those whose lymphocyte counts stay intact. This is an electron microscope showing the invasion of the virus into the T cells. Here we see in a patient with ARDS enlarged pneumocytes. You get these multinucleated cells that are virally infected, the formation of neutrophil extracellular traps. The reddish stain is double-stranded DNA, and the greenish stain is RNA. By comparison, this is what normal lung looks like. And finally, the cardiac myocytes can develop focal degeneration, as shown by these blue arrows. Here you see 3 separate autopsies, all showing this right ventricular distension and enlargement. And here you see virus within pneumocytes. And in this EM, in a different patient, you see virus within renal tubular epithelium. Let's not forget about arterial thrombosis associated with COVID. This patient succumbed to stroke. Here you can see brain infarction with surrounding hemorrhage. Here is a brain microthrombus, and also a myocardium microthrombus, and also a portal vein, a portal venular microthrombus. Let me tell you about my first patient with COVID-19, an 82-year-old white male. He's been my patient since 2010. He had 2 non-STEMIs, an LV ejection fraction of 45%, paroxysmal atrial fibrillation. He's a retired Boston police officer. He lives alone in a large single house, and his son, who's an emergency department physician, set up an agency-hired nurse assistant to help care for him. Well, it turns out that she, the CNA, had a roommate who developed COVID. My patient started off with a cough and a low-grade fever before this knowledge about COVID was evident. He did not respond to a Z-Pak. He was brought to our community hospital, the Brigham and Women's Faulkner Hospital, on Friday, April 3, tested COVID positive, was triaged to our step-down unit, and was doing okay. And then Saturday night, April 4, he had sudden, rapid respiratory decompensation, which is typical of the illness. You can be cruising along and then suddenly spiral downhill. He was made comfort measures only at 3 a.m. on Sunday and expired several hours later. Look what happened between his admission chest X-ray showing COVID pneumonia and 24 hours later. So this is a devastating disease. I never thought he would pass away from a viral pneumonia. I always assumed that ultimately he'd have cardiovascular demise. Now, what has happened is that the death rate is highest in those who are elderly. My patient was 72, and you can see by far that the older you get, the higher the rate of death. Now, during our current surge of COVID, we're finding in the Northeast that the mean and median age is now less than 40 years old. And this means that fewer of our patients need to be hospitalized, and of those hospitalized, fewer need to be on mechanical ventilation. We do know that in young adults aged 18 to 34, those who have morbid obesity, hypertension, and diabetes, or any of these risk factors, have a higher likelihood of dying from COVID, despite their young age. Now, another problem has been racial and ethnic disparity in COVID, and particularly deaths from COVID. If we focus on the age standardized data from the CDC, we see the general non-Hispanic white population in blue, but in red, we see the distribution of COVID deaths. And it's much lower in non-Hispanic whites than their population. On the other hand, Hispanic deaths are double their population, and the same can be said for non-Hispanic Blacks. So, as of this past weekend, we have more than 13 million cases of COVID, and we've hit new records, more than 205,000 cases on one day, November 27th. And if we look at a 14-day rolling average, the case rate has increased by 17%. The death rate, now greater than 265,000, is getting higher. And we have a 14-day rolling average of death rate that's increasing by 36%. And the hospitalization rate is now approaching 90,000, and it's increasing over a 14-day rolling average by 40%. We're not feeling the crush in our hospitals as much as other parts of the country. Now, let's look at the 7-day rolling averages. And this is from yesterday's Wall Street Journal. You can see the three surges. The first hit New York City and the Northeast and New Jersey very hard. The second surge during the summer did not affect the Northeast at all, but was focused in warmer states, Texas, California, and Florida, and Arizona. And now what's different with this third surge is its duration. Its slope is even steeper than the first two surges, and it is now no longer regionalized. This surge is present throughout the country. And as far as the cumulative death rate, there has been no let-up whatsoever. Over the past 7 days, of all places, the highest COVID death rates are in North Dakota and South Dakota. Now, in the past, we used to say if you're in an area with lots of land and few people, you're all set. For instance, Vermont and Dartmouth Hitchcock Medical Center have had very few cases of COVID. These two states have about 700,000 in the population. They're two of the least populous states in the nation, but they've been hit extremely hard. In North Dakota, they've had almost 1,000 deaths, more than 10,000 cases, and their death rate per 100,000 is 120 patients, among the highest. Now, if we look at the Institute of Health Metrics based in Seattle, they have made their career on projections. They project that by March 1, our death rate in the United States will be greater than 470,000 Americans with our current mask use, which is estimated at 49%. If there is mask easing, they project the death rate could jump by almost 200,000 between now and March 1 to 658,000 deaths. And if there were universal masking, which is defined as 95% of the population wearing masks, this is aspirational in the US, they predict a death rate of almost 408,000. But look here, you are saving more than 60,000 lives between now and March 1. Well, 100 years ago in the Spanish flu, there was a mask controversy. The Red Cross advertised wear a mask and save your life. And then they say a gauze mask is 99% proof against the Spanish flu. Wear masks, going to work, at work, going home, and at home. On the other hand, there was the anti-mask contingent. Here, an anti-mask meeting and rally is being called for in Greenland Rink to protest against the unhealthy mask ordinance. And here we see a photograph in San Francisco showing a police officer trying to convince its mask slackers, such as this businessman on the right, to wear masks after many defied the laws and the Spanish flu pandemic took over the city of San Francisco. So one lesson is the only thing we learn from history is that we learn nothing from history. In a situation like this, which I think exists today, I turn to one of my favorite philosophers and writers, Lisa Rosenbaum, who's a cardiologist on our faculty, and she wrote in the New England Journal a thought piece on a tribal truce. How can we bridge the partisan divide and conquered COVID? She writes, masks have become a flashpoint in our culture wars. It's a symbol of either a commitment to public health or an infringement on basic liberties. The mask encapsulates the politicization of science. But since human behavior, including wearing or shunning masks, will determine the pandemic's ultimate toll, communication strategies that bridge our partisan divide over science may prove as important as any novel therapeutic. Well, here are some additional mechanisms of myocardial injury in COVID. Hypotension, direct viral cardiomyocyte toxicity, disseminated intravascular coagulation, vasculitis causing microvascular dysfunction, stress cardiomyopathy, this hyperinflammatory state, epicardial plaque rupture with a type 1 STEMI, and hypoxia and increased metabolic demands, and oxygen supply demand mismatch leading to a type 2 MI. And what we see is that hemostatic abnormalities in adverse clinical events and clinical outcomes really come together with the risk factors we've discussed, the inflammatory response, the array of hemostatic abnormalities, in addition to an elevated D-dimer, we see elevation in fibrin degradation products, prothrombin time, and a decrease in the platelet count. And this can manifest in many different ways. Venous thromboembolism, both micro and macro, myocardial infarction, and on rare occasions, DIC. Well, in China, back in January, the Chinese physicians noted that those who developed DVT with COVID-19 had lower survival rates than those who had COVID-19 but did not develop DVT. And they also noted that those who had very high D-dimer levels, we're talking about D-dimer levels of 4,000, 5,000, even higher. In our assay systems, usually most of the assays don't measure greater than 4,000 nanograms per ml. Those patients had a poor prognosis. And we see the involvement of NETs. These neutrophils shown here bear markers of NETs. They're trapped in the platelet-rich clot, which is seen in red. And these microthrombi are found in the lungs of patients with severe COVID-19. Well, we've undertaken several studies of COVID-19. One of them just published on November 3, Election Day, we called CORONA-VTE. It is a dynamic, retrospective, and prospective observational cohort study across the Mass General Brigham network. You may be wondering what that is. Mass General Brigham, or MGB, is the new name for Partners Healthcare. That name's been retired. And what this network does is it gives us a silent, updatable, in-epic best practice advisory, which identifies every COVID-19 positive patient within the network. The two largest hospitals are MGH and the Brigham, but there are about 8 other hospitals in the network. And we could follow, based on the records in EPIC, the 30-day rate of VTE, stroke, MI, myocarditis, heart failure, arrhythmia, and death. And these outcomes were adjudicated by a centralized endpoints committee. And we've already obtained data on more than 2,000 patients with complete follow-up. So on November 3, we published in JACC our findings on the initial 1,100 patients with COVID. And here, we're not showing the entire group, we're just showing those patients who were hospitalized in an intensive care unit. And we see that the arterial and venous thromboembolism rates were 36%, MACE was 47%, and symptomatic VTE, despite VTE prophylaxis in about 90% of the patients, still occurred in 27% of those in the ICU. Now, we found that the increased odds of adverse events of these COVID patients in the ICU really were not affected by VTE prophylaxis, but acute respiratory distress syndrome increased the likelihood of MACE, and so did an elevated D-dimer level. Now, here we chart the proportion of patients without major arterial or venous thromboembolism. If they're inpatients, not in the ICU, we found that almost all of them did well without thrombosis, but that was a different story for those who were in the ICU. In the proportion without MACE, same thing. There was some MACE, but not much. in the inpatients who were in step-down units, but for MACE, you see here, it's about 35–40% had some major adverse cardiovascular event, such as stroke, MI, or cardiovascular death during this first 30 days. In terms of the proportion without symptomatic VTE, it was very low in those patients hospitalized in step-down beds. But again, despite prophylaxis, you can see about 25% of the patients developed symptomatic pulmonary embolism or symptomatic DVT. So the 30-day outcomes really varied greatly by the care location. For outpatients, there was almost no cardiovascular outcome whatsoever, shown here. For the hospitalized non-ICU patients, there were some thrombotic events and some MACE, but not very much compared to those patients who were hospitalized in the ICU, where 35% had a major arterial or venous thromboembolism, 45% had a major cardiovascular event, 27% suffered symptomatic VTE, and the all-cause mortality was 23%. Now, what are the current guidelines for VTE prophylaxis in COVID-19 patients? There are two sets of recommendations, the ACCP recommendations and the ISTH recommendations. The ACCP recommendations are very conservative. They favor low dose, low molecular weight heparin for those patients who are hospitalized, and really don't make any distinction between the non-critically ill and step-down units and those who are in intensive care units. They don't recommend any prophylaxis after hospital discharge for any of the patients. I think the ISTH recommendations are more textured and more up to date. They recommend using either prophylactic dose low molecular weight heparin or half therapeutic dose low molecular weight heparin for patients high risk in the ICU. For non-critically ill patients in step-down units, they recommend low molecular weight heparin at prophylactic doses. And after discharge, they recommend either continuing low molecular weight heparin or prescribing a DOAC for up to 30 days if the patient is considered both at high thrombosis risk and low bleeding risk. Both sets of guidelines recommend no routine prophylaxis in patients who were never hospitalized.
I mean, I've never really, it doesn't really mean anything for me.
Yeah, sure.
Let's look at this paper that characterizes myocardial injury, compares elevated troponin levels and their prognostic power with echo in COVID-19. And of course, Marty Goldman is the senior author. And in the 305 patients that were studied, the right ventricle really plays a very important role, as does, as you'd expect, the left ventricle diastolic dysfunction and global LV dysfunction. But right ventricular dysfunction was present in 26% of these 305 patients. Another important paper looks at RV remodeling to prognosticate COVID survival. This was a multi-centered registry of 510 patients with COVID-19. They were clinically characterized. They all underwent transthoracic echo, and they had serologic biomarkers obtained. Then there were core lab analyses of RV structure and function, LV structure and function, and estimated pulmonary arterial pressure. There was clinical follow-up with a focus on hospital discharge and mortality. And the first observation was that the greater the right ventricular dimension, the greater the degree of right ventricular function. Whether that was looking at TAPSY and S prime, TAPSY alone, S prime alone, or an estimated pulmonary arterial systolic pressure. Now, RV dysfunction, RV dilatation, and remodeling lowered the likelihood of survival. Look at the difference in survival here, with those with RV dysfunction shown in light blue, and those without RV dysfunction shown in purple. Quite a huge difference in 30-day survival. Here, we look at RV dilation, not as dramatic a difference in survival, but still an important 10–15% absolute decrease in survival among those who had RV dilation. And finally, looking at RV remodeling, we see again a huge difference in outcome. Those who have adverse RV remodeling have a much lower cumulative survival than those who have no RV remodeling. So what we can say in terms of the key findings that RV dilation and dysfunction are common in COVID patients, and RV dysfunction increased stepwise with RV dilation, and RV dilation and dysfunction each independently augmented mortality risk. And importantly, adverse RV remodeling provided incremental risk stratification beyond biomarker strata, and in particular troponin. So you see here that if you are troponin positive, but adverse RV remodeling negative, you have pretty good survival despite COVID. But if you have a combination of troponin positive and adverse RV remodeling, you're in the lowest survival group. So adverse RV remodeling really doubles the mortality in COVID-19. And you can see that this adverse remodeling can come from many different directions. It can come from the viral infection directly into the myocyte. It can come from cardiogenic shock. It can come from mechanical ventilation in PEEP. And it can come from direct myocardial ischemia. So this adverse remodeling increases preload and afterload, and this leads to more dilation and dysfunction of the RV, which causes a greater mortality in COVID-19. Well, what happens after the first several years? We don't really know. We haven't gotten there yet. But let's imagine what might happen. We're familiar with the acute time course over the first few weeks and even the convalescent time course. But what's going to happen over the next few years? Will patients develop pulmonary fibrosis from ARDS? Will they have multiple cardiovascular risk factors such as hyperlipidemia? We don't really know for sure. But I've noticed in my own practice, new patients referred to me with what I can only call a post-COVID syndrome. In this study of post-COVID syndrome, there were 143 patients, mean age 56 years, 37% women. They were assessed on average 60 days after their first COVID symptoms. Only 13% were asymptomatic. The rest had symptoms such as persistent fatigue, dyspnea, joint pain, or chest pain. And I think we as cardiologists are going to see more patients referred to us for dyspnea and chest pain. In that same paper, they showed the symptoms during the acute COVID-19 phase and after it. And I think you see that about 80% of the patients had fatigue, about 70% dyspnea, 55% joint pain, and 40% chest pain during the acute phase. The problem was that after the infection, 60 days later, when they tested negative for COVID, we still have more than 50% with fatigue, more than 40% with dyspnea, more than 25% with joint pain, and more than 20% with chest pain. And we don't really know how to manage these patients. I know that Cedars-Sinai in Los Angeles has started a multidisciplinary COVID clinic that's run by cardiologists. I am going to ask you whether at Mount Sinai the same is true. Well, the last few slides I have are on acculturation, or the new normal. During the height of the first surge, I took this photo. Gas was $1.85 per gallon. Back in 1955, the regular price for gas was 25 cents per gallon. But if you account for inflation, it would be $2.43 per gallon in 2020. So gas now is actually less expensive than it was many years ago. And note also, this is in a Sunday morning when this street called Center Street in West Roxbury is usually crowded and not a single car. At one point, there was so much a glut of gas, all the storage tanks were filled, and those who had purchased large quantities of gas could only find ships to store it in. And so those who bought the gas were paying $40 per gallon to store it. And now gas is selling for about $40 per gallon. With all this decrease in driving, we saw just within a few months a marked decrease in air pollution and nitrogen dioxide from these satellite photos. But I'm not sure what's going to happen with the vaccines that have become available for COVID. We know that there is a lot of suspicion of vaccines. The most recent polls say that 40 to 50% of Americans will not take the vaccines that become available for COVID. And here you see a recent demonstration when our governor insisted that school children in our public schools be vaccinated against the flu. So on my last slide, my conclusions are that COVID-19 is waxing and waning. It is not disappearing. And I'm not sure it will ever disappear. We might need booster shots yearly like we do for influenza. Inflammation plays a key role in the ARDS patients with COVID-19, precipitating pulmonary embolism, DVT, myocardial infarction, and stroke. Ethnic and racial minorities suffer disproportionately from COVID-19 and from its thrombotic complications. Ongoing research will ameliorate suffering and decrease mortality, but is unlikely to eradicate COVID-19 even when vaccines become available. I do think that the post-COVID syndrome will become more frequent and problematic. It reminds me of the post-pulmonary embolism syndrome and the post-phlebitic syndrome, but appears to be much more devastating. And COVID-19 has a profound effect on daily life with psychological, economic, and social disruption of almost unprecedented extent. So in summary, it's a real privilege to speak with you. You were in the midst of it all in New York City. We had some learnings from what you were saddled with when we had our surge. And I think that we have an unprecedented amount of regional cooperation, and the Northeast, though hit by this third surge, so far has been hit less hard than most of the rest of the country. Thanks very much.
Sam, thanks. That was great. If you can address two things. One is, with your expertise in thrombotic state, how do you deal with anti-thrombosis, anticoagulation in the post-COVID syndrome patients? And then secondly, what do you think the impact of the vaccine will do in changing what we see as the natural history in the post-COVID syndrome and opening up?
Two great questions. What I didn't discuss is a trial, a randomized controlled trial that we have leadership in, looking at patients who were never hospitalized after COVID, which that's the vast majority of patients, and we're randomizing them for a 30-day trial of rivaroxaban 10 milligrams daily versus its placebo, and we're seeing if that leads to fewer cardiovascular adverse outcomes after they're COVID negative in terms of the viral infection. So we are in the midst of the randomization, and there's a very tight timeline, and maybe a year from now we'll have the results. We're trying to enroll 10,000 patients at 6 centers across the United States. We started this in the summer, and we were worried that things had quieted down, certainly in the Northeast, but now that's obviously no longer the case. As to what the vaccine will do, it's very difficult to say because the few patients I've worked up with post-COVID syndrome have been patients who've been previously extremely healthy. And I've really, now they're they could be a marathon runner now, disabled by dyspnea on exertion. And really, their pulmonary function tests, their cardiac MRI, their echoes, their cardiopulmonary exercise tests, so far in my limited experience, have been normal. So I'm not quite sure how to counsel them and what to say to them. I'll be very interested to hear what your group is doing on this.
Sam, thank you very much for your wonderful talk and an overall view of a very complex entity. And I just like to go back to the issue of the antithrombotic agents. And that is, I actually have a couple of questions. At this present time at the Brigham, as a policy, the patient is admitted with COVID. What do you do from the antithrombotic point of view? Do you use them? Do you don't? You wait for some evidence that's clotting? What do you do?
Well, we changed our policy in the midst of the first surge when we saw all these patients developing thrombosis in the ICU on standard prophylaxis. So for any patient who is hospitalized in an ICU at the Brigham, we give them, for example, enoxaparin 40 milligrams twice a day instead of the usual enoxaparin 40 milligrams once a day. And for patients who are hospitalized in the step-down unit, we give them standard VTE prophylaxis. That's what we've currently written in our own internal guidelines.
But what about the patient that is hospitalized and actually doesn't go into the intensive care unit?
Yes, we give those patients standard VTE prophylaxis, preferably with enoxaparin 40 milligrams once a day.
When the patient is discharged, what do you do?
That is a great question. We should be enrolling those patients into a study, but we aren't at this time. And I think there's quite a bit of variability. But I think for the most part, those patients who are discharged from a step-down unit do not get any prophylaxis, and the patients who make it survive the intensive care unit are usually getting some prophylaxis, but that's dependent on who's caring for them at the time.
Thank you.
Sam, Jeffrey Olin, how are you?
Good, Jeff. I just referred a patient to you over the weekend.
I wanted to ask you something. Where does this concept of intermediate dose anticoagulation come from? You guys are doing it, people here are doing it, but to yet I've not seen any data that suggests that really helps. If prophylaxis is not helpful, why are we not using full dose anticoagulation?
Well, there is a trial going on exactly that point, Jeff, but I think the reason we're not using full anticoagulation in our ICU patients is we are concerned that they might have severe major bleeding, particularly bleeding from their lungs. So that's why we're using this intermediate dose of prophylaxis.
So Sam, hi, this is Greg Stone. Let me follow up on that. There's been a unique phenomenon that I've noticed. There were so many cases and so many deaths in this pandemic that, of course, all well-meaning physicians are trying to do anything we can to get a grasp on it. So I noticed early on that the usual rigor in which we apply evidence-based medicine basically fell by the wayside. Sometimes therapies would get started in all patients based on either in vitro data or perhaps poorly controlled observational studies such as hydroxychloroquine or others. Sometimes those therapies were either not helpful or were actually harmful. So I guess I'd ask a general question. What do you feel in the midst of a pandemic, or we're in this new situation where we don't really have time to generate evidence, or maybe we do, but it could cost lives? Do we follow our usual principles of evidence-based medicine, or do we relax them and try by good conscience to, treat patients how best we can, both ethically and, clinically as a physician?
Yeah, well, that's a very profound question. I think on the research, I've seen research accelerated in ways I could never have even dreamed of. We went from monthly IRB meetings to daily IRB meetings. The protocol that we're doing on outpatients was submitted and approved within 48 hours. So I think there is a real genuine effort to accelerate and encourage research as much as possible. In the meantime, we certainly for a while, during the first surge, we were giving hydroxychloroquine, and I think the Mass General was also giving a Z-Pack on top of it, and we weren't quite sure whether we should. We were a little more conservative, and now we don't do either. And when remdesivir got approved for all ICU patients, we were initially giving it. So I think we use our conscience and our intuition, and we don't have the luxury of as much evidence-based medicine as we might otherwise have. I do think we've done a great job, though, in monitoring what we've been doing, and when we see something is not effective, like hydroxychloroquine or azithromycin, we've been very good about changing course frequently. And so we're certainly, as a community of clinicians, we're not getting stuck in our ways. We're looking toward the future.
No, I understand. It just makes it hard to enroll, for example, in randomized trials when people say, I have to treat everyone with hydroxychloroquine. And we might have gotten the answer much sooner from, well-done randomized trials. So sitting up high in the ivory tower, it's easy to say, no, we should only treat patients with established therapies. But, down in the trenches, it's much, much more difficult.
Let me give you a little different viewpoint. In the vast majority of patients who were never hospitalized, we have found tremendous uptake in our outpatient study. And we found that from patients of all walks of life, racial and ethnic diversification. There has been tremendous enthusiasm with them. And of course, we've also checked with their primary care doctors before enrolling them in this trial called CORONA-VTE, and we've gotten tremendous support there. So there might be a difference between those patients who are hospitalized and what the attitudes are that you're sensing, and those who are managed as outpatients.
Thank you.
A comment, if no one is paying attention to the chat box, Amy Kontorovich was kind enough to summarize what we're doing here at Mount Sinai, as well as a link to our initial series.
Great. Please send it to me.
Sam, I think if there are no other questions, I just wanted to thank you very much for a very comprehensive update on COVID-19 up to yesterday's statistics. And obviously, we'll have to have you come back and give us an update on your randomized trial. Thank you very much. Good seeing you again.
Thanks for
Thank you. Thank you,
See
Sam.
you, my friends and colleagues.
Have a great day.
Thank you.
Bye-bye.
Bye-bye.